Copper is one of those minerals where the online story gets huge fast. Energy, nerves, immunity, collagen, brain chemistry. The sober version is smaller but still important. Copper is required because enzymes use it to move electrons, handle oxidative stress, support connective tissue, and help iron move into usable blood-making pathways. That does not mean more copper equals more benefit.
So if copper is in food and the body needs only a trace amount, why would anyone take a copper supplement at all? Is the real issue low copper intake, poor absorption, or people accidentally pushing it down with other supplements?
Exactly. The cleanest reason to use copper is suspected or confirmed deficiency, not vague optimization. Context matters. People with altered gastrointestinal anatomy, malabsorption, prolonged inadequate intake, or heavy zinc exposure are more plausible candidates. A rapid review of late post-bariatric surgery case reports found copper among the more frequently reported micronutrient deficiencies, sometimes years after surgery, which is why follow-up matters. Food exposure is also different from pill exposure. Copper comes packaged in a meal, absorbed under normal regulation, and balanced with other nutrients. Supplements can be useful, but they compress dose into a small tablet and bypass the natural friction of eating. That is why a trace mineral should be treated less like a daily upgrade and more like a correction tool.
Can you walk me through the body ladder here? When someone says copper helps nerves or blood, what is the chain from swallowing it to an actual tissue effect?
After absorption, copper is moved and stored carefully because free copper can be reactive. The useful copper is the copper inserted into enzymes. Those enzymes participate in iron handling for red blood cell production, antioxidant defense such as copper zinc, superoxide, dismutase, connective tissue cross-linking, and nervous system function. So the credible claim is not stimulation. It is restoring enzyme capacity when copper is limiting.
That sounds useful, but it also sounds like a mineral the body does not want floating around freely. Is this why high-dose copper feels riskier than, say, taking a basic multivitamin? The zinc interaction is the part people seem to miss. If someone takes zinc every day for immunity, skin, or colds, how can that create a copper problem instead of just raising zinc?
The practical version is that excessive zinc exposure can impair copper availability. The systematic review of zinc-induced hematologic toxicity collected 37 human cases across decades. Sources included oral supplements, denture adhesive creams, and coin ingestion. Reported elemental zinc exposure ranged from about 50 milligrams per day to more than 1,500 milligrams over weeks to years. What made those cases clinically important was not a subtle wellness score. Nearly all had anemia, often with neutropenia or leukopenia, and severe prolonged cases could show pancytopenia. Serum copper was reduced in all patients. Some bone marrow exams looked alarming, with vacuolated precursors and ring sideroblasts, sometimes leading doctors first toward myelodysplastic syndrome before zinc-induced copper deficiency was recognized.
That is more concrete than the usual supplement pitch. What about nerve health specifically? If copper deficiency affects nerves, does copper supplementation reliably reverse numbness, walking problems, or weakness?
This is where expectations need to be very careful. In the review, stopping zinc exposure plus copper supplementation led to hematologic recovery in most cases, typically over weeks to months. Neurologic manifestations improved more slowly and were sometimes incomplete, so numbness, gait changes, weakness, or unexplained anemia are not reasons to guess with copper. They are reasons to get evaluated.
How should viewers weigh the evidence? We have mechanisms, case reports, and deficiency treatment logic. But do we have strong trials showing copper supplements make already healthy people feel sharper, stronger, or more energetic?
For general enhancement, the evidence is weak. NCCIH's broad supplement guidance is useful here. Evidence varies widely, products differ from those tested, and supplements can interact with conditions or medicines. There are niches where copper appears inside multinutrient studies, but a secondary analysis in children with ADHD linked copper changes to oxidative stress markers, not a clean copper alone treatment recommendation. A good example is stuttering. A 2020 systematic review looked at pharmacological and dietary treatments for developmental stuttering and found dietary approaches, including copper, had insufficient evidence. That does not prove copper is useless in every person. It means the public claim has outrun the clinical data. Deficiency treatment and disease treatment are different categories.
If someone and their clinician do decide copper is appropriate, what practical boundaries matter? Should they be checking the label for elemental copper, looking at their zinc dose, and avoiding products that stack several minerals without making the totals obvious?
The best feedback is not a same-day feeling. It is a monitored change in the reason copper was started. Copper status, blood counts, zinc exposure history, and symptoms over time. If the problem is zinc-induced deficiency, removing the excessive zinc is part of treatment. If the problem is post-surgical malabsorption, long-term follow-up and a complete supplement plan matter more than one isolated mineral.
So the red flag version is, do not use copper to casually treat unexplained anemia, low white cells, tingling, or trouble walking at home. Is that also because excess copper itself can be harmful and because the wrong diagnosis could be missed?
Bottom line, copper is biologically important, but copper supplements are most convincing as targeted replacement, not broad optimization. The highest yield question is not, what miracle does copper perform? It is, why would my copper be low and how would we verify improvement? Watch zinc dose, respect post-bariatric and malabsorption contexts, use food as the default, and bring blood or nerve symptoms into medical care early.